afternoon, respected chairpersons and moderators, and my dear fellow colleagues. Uh, it is my honor to be here to present our recent work on the mid-treatment planning necessary for all head and neck patients or not. So I'll try to go through this. So this is just an overview of our department. Currently, we are using 3 linear accelerator variant and 2 telecobles and 2 HDR machine. And approximately, we have been treating around 4,500 patients per year. So imagine that you are treating a patient with head and neck cancer, and after 2 to 3 weeks, you see the weight has dropped, the contour of a neck diameter had changed, and you are wondering what is my plan still valid, or should I replan now? Because when you are thinking about the replanning, because replanning is not always necessary, even it is not always useful for the world patient. So because you need, when you are thinking, you need time, you need staff, you need machine, and definitely you have to consider about the cost for replanning. So what could be the solution? So this question poses me to carry on my research on whether all the patients need replanning in mid-treatment verification, or can we be selective, or only those patients who need really the mid-plan verification, so we'll only go through this. So we try to design a model that is based on the risk, and we will focus those patients are high risk, and we will replan only this. So this is just a transformation from 3D CRT to our today's adaptive radiation therapy. Historically, we started from 3D CRT, and now we are 3D CRT to the IMRT. So what we can see only the tumor and anatomy of the patient. And this, after this transitioning from 3D CRT to IMRT, and now we are in the adaptive radiation therapy, that is the functional or biological volume based. So what we can see the tumor, normal tissue before and after the treatment, even during the treatment. So where we are, so we are now between the transition of the modern technique like IMRT and VMAT and the adaptive radiation therapy. So as we were talking, so is this the mid-treatment verification? Is this adaptive? Because there's a difference of the mid-treatment verification and the adaptive radiation therapy. Only the mid-treatment verification, you only verify whether patient position is correct, is there any change, anatomical or dosimetrical, but you are not performing your correction. So in adaptive radiation therapy, you are taking seriously, you are changing the plan, you are replanning it, and you are treating the patient according to your replan. So the recent literature, a lot of recent publication that shows the adaptive radiation therapy, that a lot of clinical benefits, and if you according to the local regional control and that acute and late toxicity. But most of the cases, you see the dosimetric benefit is more comparing to the clinical, because you see in this literature the mean parotid dose is decreased, spinal cord is decreases when you are replanning, and definitely that improves the target coverage. So I designed my study. We selected 20 patients, stage distribution and prescription dose, and also we took the CBCTs and the initial plan and as a baseline and twice weekly, and then we do the resimulation at 20 number of and at 20 fraction, and all the patients are treated with VMAT technique. So this is our data acquisition. We count the GTV regression, parotid gland displacement, and neck diameter reduction, and also we calculated the plan and analyzed the PTP and wear doses. So this is just anatomical changes, what we observed in our study. The GTV shrinkage, if you see the initial plan and at 20 fraction, the patient, at least the 65% patient, that means the 13% patient out of 20 patients that reduce the GTV shrinkage, and 30, if the patient GTV shrinkage is more than the 30%, we draw this we consider as a threshold limit. Similarly, for the parotid medial shift, we calculate the medial shift of the parotid. We draw a baseline from the patient and midline, and then we calculate the shift from the initial plan and mid-treatment verification. Here also we draw a threshold at if the medial shift is greater than 3 mm, then we consider the patient for the replan. So also the neck diameter, among the 20%, 12% patient have the change of 5 millimeter, more than change of 5 millimeter of neck diameter. It is almost 60% of our study. The dosimetric analysis among 20 patients, we can see that reduce of the dose, that we said the criterion that D98 should be passed. We see that on the 6th patient failed to this criteria. So in dosimetric analysis, for the parotid mean dose, we almost the 45% patient below the threshold limit. And we also analyze the toxicity assessment for the mucositis, dysphagia, and xerostomia, and the skin reaction, where the most of the patient, all the patient developed the grade 2 toxicity, no patient developed grade 3 toxicity. Mucositis is 60% patient, dysphagia 50%, and almost the xerostomia and skin reactions are same for all the patients. So that is our main focus. We then design a risk stratification tools based on the weight loss, parotid shift, dose deviation, GTP synchrase, and neck diameter. And you see the clinical and planning criteria. If for weight loss, if the patient lose their weight greater than 5%, then we scoring that. If parotid shift, if it is the less, greater than 5 millimeter, dose deviation also the greater 5%, then we consider as this criteria. So what you design, so if the total is score 0 to 2, we categorize as a low risk and also color code green. So this is a minimal change. That means we can continue the current plan. And if the score is 3 to 5, then we categorize as a moderate risk, and that is defined by the yellow color. And we have to monitor the patient closely and consider adaptive treatment. And if the risk score is greater than higher, then we consider this patient as a high risk and significant change. That means we need resimulation and replanning. So we found our study that the 35% patient is low risk, 35% is high risk, and the moderate risk is 30% of among the 20 patients. So the take-home message is the high-risk patient require adaptive planning. Moderate risk, we should follow the follow-up, close monitoring. Low-risk patient continued safely and initial plan. And we have definitely adaptive assessment that improve the PTP coverage and reduce the weird doses. And that's why we designed the mid-treatment stratification that helps to identify those patients who really need this. So thank you very much.
Thank you. Thank you.